Welcome to our video on common adult orthopedic injuries of ankle and foot. Let's get started. In this lecture, we'll cover ankle injury and the Ottawa ankle rules, syndesmotic or high ankle injury, Achilles tendinopathy and rupture, calcaneal epiphysitis or Sever disease, plantar fasciitis, calcaneal stress fracture, and tarsal tunnel syndrome. Let's begin by defining and distinguishing ankle sprains from ankle fractures. The term ankle sprain describes injury to ankle ligaments, such as the anterior talofibular ligament and the Calcaneofibular ligament or the deltoid ligament. Among these, injuries to the anterior talofibular ligament and the Calcaneofibular ligament comprise about 90% of all ankle sprains, and they're often cited as the most common reason for missing sports events. The term ankle fracture, on the other hand, describes injury to ankle bones. Here's an illustration depicting the basic anatomy of the ankle from the medial view and the lateral view. The deltoid ligament can be seen here on the medial side of the ankle, and its primary function is to limit eversion of the foot. Both the anterior talofibular ligament and the Calcaneofibular ligament can be seen on the lateral side of the ankle, here and here. The anterior talofibular ligament connects the fibula to the anterior portion of the talus, and it has two primary functions. It limits anterior location of the foot on the tibia, and it limits inversion of the foot during plantar flexion. The Calcaneofibular ligament connects the fibula to the calcaneus, and its function is to limit inversion of the foot during dorsiflexion or when the foot is in a neutral position. Understanding the functions of these three ligaments is helpful in understanding their most common mechanisms of injury. The anterior talofibular ligament is typically injured following forceful plantar flexion and inversion of the foot. This should make sense because, as we discussed on the previous slide, this ligament confers resistance to inversion of the foot during plantar flexion. The Calcaneofibular ligament, on the other hand, is typically injured following forceful dorsiflexion and inversion of the foot. This is because the Calcaneofibular ligament confers resistance to inversion of the foot during dorsiflexion. Lastly, since the deltoid ligament functions to resist eversion of the foot, it can be injured following forceful eversion of the foot. The risk factors for ankle sprains are mostly related to physical activities that predispose individuals to the aforementioned mechanisms of injury. Examples of such activities would be professional dancing and indoor court sports, such as basketball. Patients who sustain an ankle sprain typically present to a clinician with a chief complaint of pain with weight bearing on the affected leg. Physical examination usually reveals tenderness to palpation and swelling over the injured ligaments and potentially a positive anterior drawer test, which is a special test of the ankle that is similar to the anterior drawer test of the knee. Here's what the anterior drawer test of the ankle looks like. To perform this test, the clinician grabs the heel with one hand and stabilizes the tibia and fibula with the other hand. The clinician then draws the heel anteriorly with respect to the tibia and fibula and pays careful attention to the amount of anterior translation. Anterior translation of greater than 1 centimeter compared to the healthy contralateral ankle is strongly suggestive of ligamentous injury. If this test is performed in plantar flexion, abnormal findings are suggestive of injury to the anterior talofibular ligament. If this test is performed in dorsiflexion, on the other hand, abnormal findings are suggestive of injury to the Calcaneofibular ligament. In this particular case, no abnormalities are noted. The diagnosis of ankle injuries is one of the most commonly tested concepts on the boards. This is because there is a critical difference in the diagnostic approach of ankle sprains versus ankle fractures. Ankle sprains are diagnosed clinically based on history and physical examination alone. Imaging is not warranted in the diagnosis of ankle sprains. In contrast, ankle fractures require imaging for proper management. Since ankle injuries are among the most common chief complaints presenting to primary care offices and emergency departments, the Ottawa ankle rules were created to help clinicians reliably distinguish these two pathologies based on physical examination alone. These rules are 96 to 99% sensitive in ruling out ankle fracture, and thus help clinicians avoid ordering unnecessary x-rays when patients present with ankle sprains. Based on the Ottawa ankle rules, a clinician should strongly consider obtaining an X-ray of the ankle if the physical exam reveals pain in the malleolar zone and either one of the following: tenderness to palpation along the distal 6 centimeters of the posterior edge of the tibia or tip of the medial malleolus, or tenderness to palpation along the distal 6 centimeters of the posterior edge of the fibula or tip of the lateral malleolus, or inability to bear weight for 4 steps, that is, 2 steps on each foot. Here's an illustration we've seen earlier in the presentation depicting the basic anatomy of the ankle from the medial view and the lateral view. Here's the area of the ankle defined as the malleolar zone by the Ottawa ankle rules. Here's the distal 6 centimeters of the posterior edge of the tibia and the posterior tip of the medial malleolus on the medial view. And here's the distal 6 centimeters of the posterior edge of the fibula and the posterior tip of the lateral malleolus on the lateral view. Focal tenderness to palpation in these areas on physical examination would be highly suggestive of an ankle fracture and thus warrant x-rays of the ankle. Despite the name, the Ottawa ankle rules also contain recommendations regarding pain in the foot. A clinician should strongly consider obtaining an x-ray of the foot if the physical exam reveals pain in the midfoot zone and either one of the following: tenderness to palpation at the navicular bone, or tenderness to palpation at the base of the 5th metatarsal, or an inability to bear weight for 4 steps or 2 steps on each foot. Focusing now on the anatomy of the foot, here's the area of the foot defined as the midfoot zone by the Ottawa ankle rules. The navicular bone is located here on the medial side of the foot. The base of the 5th metatarsal, on the other hand, is located here on the lateral side of the foot. Focal tenderness to palpation at either of these bony parts of the foot would be concerning for a foot fracture. When it comes to management of ankle injuries, most ankle sprains are managed non-operatively with rest, ice, compression, elevation, and physical therapy. Surgery is typically reserved for patients with substantial tears in ankle ligaments or for patients that did not respond to conservative treatments. Management of ankle fractures is more involved and typically requires either a short leg walking cast or open reduction and internal fixation in particularly severe cases. For the purposes of the USMLE Step 2, students are not expected to distinguish indications for casting versus operating on ankle fractures, and examiners are unlikely to present you with both of these options as potential correct answers. Answer choices are likely to include either one or the other. All right, let's try a question. A 16-year-old male is brought in to his pediatrician following a basketball game in which he sustained an injury to his right ankle. On physical examination, his ankle looks swollen and is diffusely tender to palpation. There is no focal tenderness over the malleoli or the posterior ankle. He is able to bear weight for 8 steps, although he is somewhat limited by pain. What is the next best step in management? All right, the question vignette describes a classic presentation of an ankle sprain. Since there is no tenderness to palpation over the malleolar tips or the distal 6 centimeters of the posterior edge of the tibia or fibula, and he is able to bear weight for more than 4 steps, an ankle fracture is unlikely and imaging is not warranted. Hence, the next step in management would be to treat the ankle sprain with conservative measures, such as rest, ice, compression, elevation, and potentially physical therapy. So far, we've discussed injuries pertaining to the lower ankle. Now let's take a moment to discuss a special type of ankle injury known as the syndesmotic or high ankle injury. A syndesmotic sprain is an injury sustained to syndesmotic structures of the ankle that leads to ankle instability. Generally speaking, syndesmotic injuries comprise about 10% of all ankle injuries. The term syndesmosis describes a strong membrane or a group of ligaments that link 2 adjacent bones to form a fibrous joint. The most commonly discussed syndesmotic structure of the ankle is the interosseous membrane between the tibia and the fibula. As such, it would be sufficient to think of syndesmotic sprains as injuries to that interosseous membrane. The most common mechanism of injury is forceful dorsiflexion and eversion of the foot. Physical examination may reveal pain and swelling around the ankle, as well as a positive squeeze test. The squeeze test is performed by squeezing the upper half of the calf in an anteromedial to posterolateral direction in an attempt to reproduce the pain at the syndesmosis. This test showed a sensitivity of about 26% and a specificity of about 88%, which is why it's best used to rule in a syndesmosis injury in the context of a suggestive history. The diagnosis is typically confirmed with X-ray of the ankle, which will reveal a wide ankle mortise or an increased gap between the distal ends of the tibia and fibula as they articulate with the foot. Management is typically non-operative with a non-weight bearing boot or cast for 2 to 3 weeks. Surgery is reserved for patients with significant ankle instability or associated fractures. Here's an X-ray depicting the normal mortise view of the ankle with the tibia and fibula. Normally, the distance between the distal ends of the tibia and fibula should be less than 5 millimeters. Therefore, a distance of more than 5 millimeters between the distal ends of the 2 bones would be consistent with a syndesmotic or high ankle injury. Let's move on to Achilles tendinopathy and rupture. Achilles tendinopathy is characterized by pain at the insertion site of the Achilles tendon on the calcaneus. The risk factors are age over 60, female sex, abrupt increase in physical activity, and the use of fluoroquinolones or corticosteroids. Physical examination typically reveals tenderness to palpation and warmth and swelling at the posterior heel. The diagnosis is clinical and can be confirmed using ultrasound or MRI. The management is conservative with rest, ice, pain control, and a specific type of physical therapy called eccentric resistance exercises. Briefly, an eccentric exercise is one that causes lengthening of the muscle while it's under tension. An example of that would be lowering the body during a pull-up. Eccentric resistance exercises are thought to reduce the long-term maximal strain on the Achilles tendon, thereby creating more favorable conditions for recovery. Let's now consider Achilles tendon rupture. The most classic history described in board vignettes is that of a weekend warrior experiencing a sudden popping sensation and acute pain during a sports event, such as basketball. Achilles tendinopathy and athletic activity are the two primary risk factors for rupture of the tendon. Physical examination will reveal limited plantar flexion and a positive Thompson test, which is a special test that will be discussed in greater detail on the next slide. Notably, plantar flexion is limited in patients with Achilles tendon ruptures because this tendon is normally responsible for connecting the gastrocnemius and the soleus muscles to the base of the heel to allow for plantar flexion of the foot. Similar to Achilles tendinopathy, the diagnosis here is clinical and can be confirmed using ultrasound or MRI. Unlike Achilles tendinopathy, the treatment of Achilles tendon rupture almost always involves surgery followed by a long leg cast for 6 weeks. Here's an animated image depicting the Thompson test, which is performed by squeezing the calf muscles. Normally, notable plantar flexion of the foot will be observed when the calf muscles are squeezed, as can be seen on the slide. If the Achilles tendon is ruptured, however, squeezing the calf muscle will not lead to notable plantar flexion of the foot. All right, let's try another question. A 65-year-old female returns to her primary care provider a week after starting ciprofloxacin for a urinary tract infection with the chief complaint of right heel pain. Physical examination reveals tenderness to palpation and warmth at the right posterior heel. What is the most likely diagnosis? All right, development of heel pain in an elderly female shortly after being started on a fluoroquinolone should always prompt suspicion of Achilles tendinopathy, which is the most likely diagnosis in this case. As a reminder, the use of both fluoroquinolones and corticosteroids have been associated with an increased risk for Achilles tendinopathy and rupture. Fluoroquinolones are known to cause collagen fiber dysplasia, leading to decreased tensile strength of the tendon. Corticosteroids, on the other hand, predispose patients to injury by masking the pain of overexertion, leading to overuse and subsequent weakening of the tendon. Now let's move on to discuss calcaneal epiphysitis or Sever disease. Calcaneal epiphysitis, also known as Sever disease, is an overuse injury of the calcaneal epiphysis, leading to bilateral heel pain that worsens with activity. Let's reinforce this point again. Bilateral heel pain that worsens with activity. The risk factors for this condition include sports, particularly running and jumping sports such as basketball, also footwear without heel padding, and growth spurts that can be seen in young children. Physical examination typically reveals tenderness to palpation at the base of the heel and a positive calcaneal compression test. The calcaneal compression test is deemed positive when the patient reports pain upon compression of the calcaneus from the medial and lateral side. The diagnosis of this condition is clinical, and the management is conservative with rest, NSAIDs, and heel cushioning. Calcaneal epiphysitis is frequently confused with plantar fasciitis, so let's cover this condition next. Plantar fasciitis is an overuse injury of the plantar aponeurosis, leading to unilateral heel pain that worsens with toe dorsiflexion and weight bearing, especially with the first steps after a long period of rest, such as when getting out of bed in the morning. This is in direct contrast to calcaneal epiphysitis, which typically leads to bilateral heel pain that worsens with activity. The risk factors for plantar fasciitis are obesity, flat feet, and frequently walking on hard surfaces. Physical examination may reveal focal tenderness over the plantar fascia, particularly at the insertion site close to the bottom of the heel. The diagnosis is purely clinical, and imaging is not necessary. However, if x-rays are obtained, they may reveal characteristic heel spurs that will be demonstrated on the next slide. Similar to calcaneal epiphysitis, plantar fasciitis is managed conservatively, with rest, NSAIDs, and heel cushioning. Here's an x-ray of the heel of a person with plantar fasciitis. The arrow is pointing to a characteristic heel spur that can be seen in chronic cases of plantar fasciitis. Heel spurs form as a result of calcium deposition following repeated stretching and or tearing of the plantar aponeurosis. Okay, let's do another question. A 13-year-old boy is brought into the pediatrician by his father with a chief complaint of heel pain. The boy says that his heels hurt when him and his little brother play basketball in their backyard. His father says his son also complains of heel pain when running around the house barefoot. Physical examination is notable for tenderness to palpation of the heel bone bilaterally. What is the most likely diagnosis? Alright, the case describes a young boy experiencing bilateral heel pain when playing basketball or when running around the house. Bilateral heel pain that worsens with activity in a young patient undergoing a growth spurt should always prompt suspicion of calcaneal epiphysitis as the most likely diagnosis. Plantar fasciitis can be considered on the differential because the boy runs a lot barefoot. However, it's less likely in this scenario because this typically presents as unilateral heel pain rather than bilateral heel pain. Furthermore, plantar fasciitis is typically worse when first stepping out of bed, which isn't the case in this question. So again, the most likely diagnosis is calcaneal epiphysitis. Let's move on to calcaneal stress fracture next, as this can often be misdiagnosed as plantar fasciitis. Similar to plantar fasciitis, calcaneal stress fractures present with unilateral heel pain that worsens with weight bearing, especially with the first steps after a long period of rest, such as when getting out of bed in the morning. The risk factors include female sex, obesity, abrupt increase in exercise intensity, and high-impact activities, such as running, that result in repetitive microtrauma to the calcaneus. The key to distinguishing calcaneal stress fractures from plantar fasciitis is physical examination and imaging. With calcaneal stress fractures, physical exam will reveal a positive calcaneal compression test, similar to physical examination findings of calcaneal epiphysitis. This special test is considered positive when the pain in the heel can be reproduced by squeezing the calcaneus medially to laterally. In cases of plantar fasciitis, on the other hand, physical examination reveals focal tenderness over the plantar aponeurosis as well as worsening of heel pain with toe dorsiflexion. This will not be observed in patients with calcaneal stress fractures. If the history and physical are suggestive of a calcaneal stress fracture, the diagnosis is confirmed with x-rays. If x-rays are negative, but suspicion for a stress fracture remains high, an MRI can be obtained as well. The management is conservative with heel cushioning and reduction in weight bearing. All right, let's wrap up this lecture with a brief discussion of tarsal tunnel syndrome. Tarsal tunnel syndrome is characterized by compression of the posterior tibial nerve as it passes through the tarsal tunnel, leading to paresthesias in the medial ankle and foot. This condition is typically unilateral. The three most common mechanisms of injury are trauma, overuse, and inflammation. Physical examination may reveal a positive Tinel test, which is performed by percussing over the medial ankle where the posterior tibial nerve passes through the tarsal tunnel. The Tinel test is deemed positive when a patient reports paresthesias with percussion over the tarsal tunnel. The diagnosis is clinical, although nerve conduction studies can be performed to confirm it. The management is conservative with rest, orthotics, and steroid injections. Surgery is typically reserved for patients who do not respond to conservative treatments, or in cases of severe fractures or dislocations that lead to compression of the posterior tibial nerve. Here's an illustration depicting the tarsal tunnel, as well as all of the structures that course through it. In essence, the tarsal tunnel is a narrow opening immediately under the flexor retinaculum on the medial side of the ankle. Although there are many structures that course through the tarsal tunnel, you only need to remember the posterior tibial nerve for the purposes of the USMLE Step 2. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing the common adult orthopedic injuries of the ankle and foot before your exams. All right, let's conclude this lecture with a multiple choice question. A 25-year-old otherwise healthy woman presents to her general practitioner with left foot pain that she first noticed 3 weeks ago when she started preparing for the Ironman triathlon. She says the pain is at its worst during exercise, particularly if she goes running first thing in the morning. Review of systems is otherwise negative. She doesn't take any medications and does not use alcohol or tobacco products. Her vital signs are within normal limits and her BMI is 27. Physical examination is notable for bilateral pes planus and tenderness to palpation over the sole of the left foot that worsens with toe dorsiflexion. The range of motion, strength, and sensation are intact in both feet. Which of the following is the most likely diagnosis? A. Achilles tendinopathy. B. Plantar fasciitis. C. Calcaneal stress fracture. D. Calcaneal epiphysitis. Or E. Tarsal tunnel syndrome. All right, the correct answer is B. Plantar fasciitis. The clinical vignette describes a young, overweight woman who recently started preparing for a challenging triathlon and now presents with unilateral foot pain. Notably, her pain is at its worst with activity, especially first thing in the morning, which is the classic pattern of pain observed in plantar fasciitis. Furthermore, her physical exam reveals bilateral pes planus, or flat foot, along with tenderness over the sole of her left foot that worsens with toe dorsiflexion, which is also consistent with the diagnosis of plantar fasciitis. Option A is incorrect because Achilles tendinopathy is more likely to present with ankle pain rather than foot pain. That being said, it wouldn't be unreasonable to consider Achilles tendinopathy on the differential, as abrupt increase in exercise intensity is a notable risk factor for it. Option C is incorrect because a calcaneal stress fracture is not supported by the physical examination described in the vignette, and it would be more likely in a case of a female athlete triad rather than a female with a BMI of 27. As a reminder, the female athlete triad is low bone mineral density, poor caloric intake, and hypo or oligomenorrhea. Option D is incorrect because calcaneal epiphysitis typically presents as bilateral heel pain rather than unilateral heel pain, and it more commonly occurs in children during growth spurts rather than adult women. Finally, option E is incorrect because tarsal tunnel syndrome tends to manifest in the form of neuropathic pain localizing to the medial ankle, which isn't the case with this patient. So again, the correct answer is B, plantar fasciitis. And that concludes this section.